Clinical, measured. Carbamazepine was developed and classified primarily as an anti-seizure medication. However, in psychiatry, it has been repurposed as a mood stabilizer, licensed specifically for the treatment of bipolar illness in patients who fail to respond to lithium. At the molecular level, its structure is highly analogous to tricyclic antidepressants. Despite this shared chemical architecture, their therapeutic applications and adverse effect profiles are radically different. When utilized in affective disorders, its efficacy is formidable. In cases of acute bipolar mania, the extended-release formulation produces a clinical response rate exactly double that of a placebo. Yet, clinical guidelines consistently relegate carbamazepine to a third-line prophylactic agent, positioning it behind both antipsychotics and valproate. This positioning is dictated by patient attrition. Clinical trials show a significantly higher dropout rate among patients taking carbamazepine, driven by an unfavorable adverse effect burden and a significant systemic management requirement. Because its high efficacy is tied to a volatile systemic risk matrix, managing carbamazepine requires a level of clinical oversight that few other mood stabilizers demand. To understand the mechanism, we have to isolate the hyperexcitable presynaptic neuron, the primary driver of both epileptic seizures and bipolar mania. Carbamazepine is a voltage-sensitive sodium channel antagonist, targeting the channel's alpha pore-forming subunit. Crucially, it's a use-dependent blockade, binding preferentially when the channel enters its open conformation. This physical obstruction directly inhibits the rapid, repetitive neuronal firing of pathological states. This upstream blockade triggers secondary neurotransmitter modulation. By limiting the action potentials, carbamazepine directly reduces the presynaptic release of glutamate, the brain's primary excitatory neurotransmitter. Downstream, it also decreases the overall turnover rates of both dopamine and noradrenaline. Because the blockade is state-dependent, targeting channels that are actively overfiring, it selectively quiets pathological circuits while largely sparing normal brain function. Translating that micro-level efficacy into systemic drug delivery introduces immediate complications. High blood concentrations of carbamazepine produce dose-related neurotoxicity, manifesting as dizziness, diplopia, and ataxia. This line graph maps two dosing strategies. The sharp, volatile curve represents an immediate release formulation. The flattened curve represents the controlled release formulation. Those sharp peaks in the immediate release curve correlate precisely with the onset of double vision, drowsiness, and nausea. By stretching the absorption over time, the controlled release preparation, dosed once or twice daily, eliminates these steep serum fluctuations and improves patient tolerability. This improved tolerability is necessary to reach effective therapeutic doses. In affective disorders, prescribers target a maintenance dose of 800 mg per day, though clinical trials frequently necessitated 1,200 mg. However, controlled release formulations have inherently lower bioavailability. Less of the active drug makes it into systemic circulation compared to an equal dose of an immediate release tablet. This forces a specific prescribing trade-off. To mitigate peak dose neurotoxicity, clinicians must increase the prescribed dose by 10 to 15%. Once absorbed, the drug travels to the liver, where it exhibits its most volatile pharmacokinetic trait. Hepatic metabolism of carbamazepine relies primarily on the CYP3A4 enzyme pathway. Carbamazepine is a potent hepatic enzyme inducer, triggering autoinduction. The drug's presence in the liver upregulates the production of the exact enzymes responsible for breaking it down. This timeline charts the consequence of autoinduction. At the start of treatment, the drug's plasma half-life is roughly 30 hours. As chronic dosing continues and hepatic enzymes multiply, the half-life drops to roughly 12 hours. The patient's metabolic baseline is actively shifting. This forces prescribers to rely on strict therapeutic drug monitoring to keep blood levels within a viable range. This bar chart displays the distinct therapeutic targets. While epilepsy can often be controlled between 4 and 12 milligrams per liter, affective illnesses require a strict minimum baseline of 7 milligrams per liter. Pushing the dose too high hits a hard toxicity ceiling. Serum levels exceeding 12 milligrams per liter correlate strongly with severe systemic toxicity. Because the enzymes are multiplying during the early stages of treatment, trough blood levels, drawn immediately before the morning dose, must be rechecked 2 to 4 weeks after any initiation or dose alteration. Autoinduction creates a shifting metabolic baseline. Clinicians must use precisely timed monitoring to keep levels from slipping into subtherapeutic failure or spiking into toxicity. The induction of CYP3A4 enzymes is not limited to carbamazepine. This upregulation accelerates the clearance of other medications the patient may be taking simultaneously. Adding carbamazepine significantly reduces the plasma levels of most antidepressants, antipsychotics, and benzodiazepines, risking treatment failure. Furthermore, accelerated steroid metabolism risks hormonal contraceptive failure. Women requiring oral contraception must use preparations containing at least 50 micrograms of estrogen. The risk flows both ways. Introducing drugs that inhibit CYP3A4, such as fluconazole or certain SSRIs, blocks clearance, rapidly increasing carbamazepine levels and precipitating toxicity. Beyond metabolic interactions, the drug carries idiosyncratic dermatological risks. A generalized erythematous rash occurs in about 3% of patients. More severely, carbamazepine can trigger rare, fatal exfoliative skin reactions, including Stevens-Johnson syndrome and toxic epidermal necrolysis. This vulnerability is genetically determined. The presence of the HLA-B1502 allele dictates the risk of these severe dermatological reactions. This allele provides a 70% sensitivity for predicting these fatal skin reactions, a genetic marker particularly prevalent in Southeast Asian populations. Finally, the drug exerts chronic strain on hematological and metabolic systems. Patients face persistent risks of low white blood cell counts, hyponatremia, and rare but fatal agranulocytosis and aplastic anemia. Carbamazepine's pharmacological footprint extends far beyond the central nervous system, creating a systemic risk matrix that affects the liver, the blood, the skin, and specific genetic profiles. These systemic risks inform prescribing decisions, especially in special populations. Carbamazepine is an established major human teratogen. Because acute bipolar mania frequently induces sexual disinhibition, the probability of an unplanned pregnancy is high. If the drug is prescribed to a woman of childbearing potential, highly effective contraception is mandatory, alongside prophylactic high-dose folate to prevent neural tube defects. Due to the drug's systemic impact, clinicians execute a rigorous baseline workup before treatment begins. This includes urea and electrolytes, a full blood count, liver function tests, and HLA-B/1502 genotyping. This baseline data provides the anchor points needed to track anticipated derangements in liver enzymes, sodium levels, and white blood cell counts as treatment progresses. The monitoring protocol dictates that these tests must be repeated at 6 months, then yearly or whenever clinically indicated. If treatment is stopped, the discontinuation process introduces its own set of clinical hazards. Abruptly stopping the medication removes the ion channel blockade entirely, risking a rapid relapse into severe depression or rebound mania. This graph illustrates the required discontinuation protocol. Withdrawal follows a gradual hyperbolic taper spanning a minimum of 1 month, ensuring the hyperexcitable neurons are not suddenly unmasked. Carbamazepine couples targeted neuromodulation with an aggressive metabolic profile. Ultimately, its ability to arrest acute mania depends entirely on the clinician's rigorous management of the drug's systemic impact.